We use the term ventilation to refer to the exchange of air between the atmosphere and the alveoli. If we look at our diagram in the lower right-hand side of our screen, we see atmospheric air making its way down into the alveoli. Step number one, we see gas exchange occurring via diffusion, as we've mentioned, between the air that's found in the alveoli and the blood that is in the alveolar capillaries. We see that those gases are transported throughout the body as through the blood, and then we see those gases leaving via systemic capillaries, and we see the oxygen that was in that gas used in the process of cellular respiration. So essentially, going back to our series of bullets over here, what we notice is that air goes into and out of the lungs as a result of bulk flow. Bulk flow, as we talked about in the cardiovascular system, is the movement of either a liquid or a gas from an area of high pressure to an area of low pressure. And so in this particular case, what we see is that the only two relevant pressures that we are dealing with, at least at this point, are the atmospheric pressure, the pressure that's simply found outside the body, and the pressure that's found in the alveoli. And so, simplistically, what we notice is this, that we inhale when the pressure in the alveoli goes down, and the pressure in the atmosphere is therefore greater than the pressure found in the alveoli, and so air rushes into the lungs. And then we exhale, conversely, when the pressure in the alveoli goes up, exceeding the pressure in the atmosphere, so air rushes back out of our lungs. And so we can calculate the movement of air using the equation that describes bulk flow. So in this case, flow is equal to the pressure difference in the alveoli in the atmosphere divided by the resistance. There's not much resistance here that is provided by the tubes of the airway that we talked about previously. And so the flow is primarily the result of the difference between the atmospheric pressure and the alveolar pressure. So that leads us to the question, what's causing the changes in pressure in the alveoli? Obviously the atmospheric pressure is not changing. And to understand that, we need to remind ourselves of Boyle's law. And so Boyle's law simply states that P1 V1 equals P2 times V2. So in other words, pressure at point number 1 and volume at point number 1 is equal to pressure at area number 2 and volume at area number 2. And so it's simply stating in a kind of common sense manner what we see in the diagram shown on your screen. And so here we have a piston and we have a bunch of gas molecules that are bouncing around. If we push that piston down, then we have reduced the volume, but we've increased the pressure, obviously. And then if we go to the right-hand side, we have pulled this piston up just a bit, and so we've increased the volume, but therefore decreased the pressure. And so this is, of course, what's happening in your lungs. When you exhale, you're increasing the volume, just like we've done on the right-hand side of this diagram that I'm pointing to now. We've decreased the pressure, which means that the alveolar pressure is lower than the atmospheric pressure and air rushes in. When we exhale, we are compressing our thoracic cavity and we're decreasing the volume and increasing the pressure so air rushes out. In order to understand how the lungs expand and contract, we have to understand the changes in pressures that occur within the various compartments of the lungs. There are three regions that we need to take a look at the pressure, in which we need to take a look at the pressure to understand this process. One, of course, is simply the atmospheric pressure, and so we assign arbitrarily a value of 0 to the atmospheric pressure. Obviously, that's going to vary a little bit as we go up and down in elevation, and we'll talk about the consequences that has for respiration shortly, but we always describe the pressures found inside these compartments associated with the lungs relative to atmospheric pressure. And so we assign atmospheric pressure a pressure of 0. The other two compartments that we needed to take a look at are, of course, the pressure that's found in the alveolus that we see shown here, and the pressure that's shown in the intrapleural fluid shown here. So in this particular instance, we're looking at a lung at the end of an unforced expiration. In other words, the lung is at rest at this particular point in time. No air is going in and no air is coming out. And what we see is that we have an atmospheric pressure of 0 and we have an alveolar pressure of 0. That would have to be the case if no air is going in or out. But we do notice that the pressure in the intrapleural fluid is negative at this particular point in time. And so remember that this diagram is not really to scale, it's just a conceptual diagram. You do remember that the intrapleural space, which is shown in green here, is very, very small. It's more of a potential space than an actual space. And the pressure is negative here as a result of the tendency of the thoracic cavity to expand and the tendency, as is being shown on our diagram here, of the lungs to recoil. The lungs have some elastic capacity, and so they're pulling inward a little bit, and they tend to collapse, but they don't collapse as a result of the fact that the chamber, the intrapleural chamber, is sealed. No air can get into that intrapleural chamber. There's a little bit of fluid that's located there, as we mentioned. And so this creates a negative pressure in that intrapleural space. And that's necessary, of course, in order for the lungs to remain inflated. It's important to remember that the lungs, there is no muscle that's associated with the lungs that causes them to inflate and to deflate. There are muscles, of course, that are associated with the walls of the thoracic cavity, and the diaphragm itself is a muscle. And so the lungs must remain attached to these outside walls, and they do that as a result of this negative pressure found in the intrapleural space. So the pressure in the intrapleural space must always remain negative. If we look at what happens over here in our bullet points in inhalation and at rest, then we see that during inhalation, of course, the pressure in the alveolus decreases, and so air flows in. But even though the alveolar pressure is decreasing, the intrapleural pressure is decreasing even more. So the interpleural pressure remains below the alveolar pressure. And then at rest, the alveolar pressure, of course, increases as the thoracic cavity relaxes, increasing the pressure and air rushes out. But the intrapleural pressure is still negative, as we mentioned, as a result of the recoil of the lungs and the fact that there's a vacuum there. No additional air can make its way into that intrapleural cavity. Now, the nature of this vacuum and the recoil of the lungs is powerfully illustrated in a pathology referred to as pneumothorax. And so pneumothorax, of course, occurs as a result of one of two actions. One possibility is an injury to the thoracic wall, that's what's being depicted here, that allows air to come in from the outside. And so it could occur anywhere between the ribs here. It's being shown towards the top in this particular diagram. And so this could occur as a result of a knife or a gunshot wound or a process during surgery. And so if air is allowed to come into that thoracic cavity, that negative pressure, as is illustrated in the lower point of our diagram, pulls air in, and either the entire lung or a portion of one of the lungs collapses as a result of the entry of that air. Another possibility is that the pressure is so great, for instance, in CPR that's, say, performed on a very young human whose lungs are not very well developed and therefore very sensitive. And so if air is pressed in powerfully from the inside and ruptures the lung, then air can rush from inside the lung into the intrapleural space. But either way, we have the introduction of air into the intrapleural space and the collapse of the lung as a result of that, which is referred to as pneumothorax. If we look at the process of inhalation, what we notice is that inhalation is an active process that's a result of muscle contraction. In fact, there are two muscles that contract to cause inhalation. The most important one is the diaphragm, innervated by the phrenic nerves. The diaphragm is depicted in our diagram in the lower right-hand corner of our page. And when the diaphragm contracts, it flattens. When the diaphragm relaxes, it forms this dome shape. It bounces back up, flexes back up into this dome shape that we see depicted on the far right of our diagram. And so the flattening of the diaphragm, as is being depicted here, increases the volume of the thoracic cavity vertically from top to bottom. And as the volume of the thoracic cavity increases, then air rushes into the lungs as a result of that expansion. Now, the ribs also lift during inhalation, and this is a result of the external contraction of the external intercostals. And so, therefore, an inhalation depends on the contraction of both of these muscles. We see this little series of steps located on the bottom left of our slide, and the first step is the diaphragm, and the external intercostals contract, the thoracic cavity expands, the intrapleural pressure drops, it becomes less than as atmospheric pressure. The transpulmonary pressure goes up, the lungs expand as a result of that, and as a result of that expansion, the pressure in the alveoli becomes subatmospheric, and air then flows into the alveoli. The transpulmonary pressure, perhaps we should note at this point, is the pressure difference between the alveoli and the intrapleural space, the pressure that we saw on the previous slide. And so as that becomes greater, it creates this drop in pressure in the alveolus, and that is the impetus that allows air, as a result of bulk flow, to flow into the lungs. In contrast, expiration is a passive process. In expiration, the diaphragm and inspiratory intercostals, which are the external intercostals, relax. Let's begin at the top of our figure, shown at the lower right-hand side of our screen. As a result of this, the chest wall recoils inward. The intrapleural pressure moves back towards its pre-inspiration value. In other words, it goes up. The transpulmonary pressure goes back towards its pre-inspiratory value. In other words, the transpulmonary pressure is actually decreasing in this case. It's not as great. The lungs recoil back towards their pre-inspiration size, and as a result, the air in the alveoli becomes compressed as a result of this recoil. The pressure in the alveoli becomes greater than the pressure in the atmosphere, and air flows out of the lungs as a result of that. Now, it is possible that expiration can be forced, and so this would happen during exercise, for instance. And there are two muscles that contract in order to allow expiration to be forced. One is the internal intercostals, which are another set of muscles that are located between your ribs, and as they contract, as you remember from anatomy, they allow compression of the ribs and therefore a decrease in the horizontal volume, the horizontal measurements of your thoracic cavity. There are circumstances in which expiration is not relaxed, but rather is forced. So a good example would be during exercise, when the volume of air that's coming into and out of the lungs per unit time increases greatly. And so two sets of muscles contract to allow forced expiration. One are the internal intercostals, which when they contract, they cause compression of the thoracic cavity, versus the external intercostals that when they contracted, caused an expansion of the thoracic volume. And then lastly, the abdominal muscles, interestingly. As the abdominal muscles contract, they force the diaphragm upward more rapidly than it would otherwise move, allowing the breaths to come in a much shorter time interval. Here we see a nice summary of what we just discussed and an overview of the changes in these various compartments during a single inspiration and expiration. So let's begin at number 1 here in our diagram. What we see is that this is the same figure we looked at a few slides back, and so this is at the end of expiration. So the atmospheric pressure is 0, the alveolar pressure is 0, and the intrapleural pressure is -4, meaning the transpulmonary pressure is 4 in this particular case. So we then start to inhale, and here we are at mid-inspiration. We have decreased the intrapleural pressure first because we've expanded the thoracic cavity. This has caused a slight decrease in the alveolar pressure and an increase, therefore, in the transpulmonary pressure. Obviously, the atmospheric pressure is still 0, Since we have -1 in the alveoli and 0 outside, then air flows into the lungs. Now we find ourselves at the end of inspiration. So at this point, the lungs are fully expanded. But they've reached their full volume. Air has made its way into the lungs, and so the volume has increased, and so there's no, the volume has increased, and so the pressure is not lower inside the alveoli than it is outside. So we have the lowest intrapleural pressure that we'll see because the lungs are fully expanded. We have an alveolar pressure of 0, which means our transpulmonary pressure has peaked. It's as high as it will get anywhere in this process. It's 7 at this point. Then we start to exhale. The thoracic cavity rather, is starting to decrease in size. And what we see is that the intrapleural pressure is decreased a little bit as a result of this compression of the overall thoracic cavity. And this has created an increase in the alveolar pressure. It's 1 now, +1. The atmospheric pressure is obviously still 0. The transpulmonary pressure then is 6. And this means that air flows out of the lungs because the alveolar pressure is 1 and the atmospheric pressure is 0. We make our way, and then, of course, we're all the way back to where we started. And we can look at this graph over here to the left that summarizes these changes that we've noted. So if we look at the green line, it shows the intrapleural pressure. The intrapleural pressure drops, and it's at its lowest at the peak of inspiration, as we saw just a moment ago in our sequential diagram to the right. We see the alveolar pressure that's shown in the purple line here. We saw that alveolar pressure, as you would imagine, is lowest mid-inspiration and peaks in mid-expiration, which is, of course, what causes the bulk flow of air into and out of the lungs. And obviously, we see that the breath volume peaks mid-inspiration and then, of course, is lowest mid-expiration. Thus far, we've talked about pressure and volume changes within the lungs, but to understand the relationship between the change in pressure and the change in volume, we need to talk about lung compliance. Compliance, as you recall from our discussions in Chapter 12, the circulatory system, is defined as a change in volume over a change in pressure. In other words, when you change the pressure within any object, let's say a balloon, then how much change in volume do you get? And so a balloon with high compliance, as we said in the circulatory system chapter, if you blew a little bit of air into it, then it would blow up, it would expand very quickly. A balloon that had very low compliance, you'd have to blow into it very hard to get any change in pressure at all. So the greater compliance, the more change in volume you have when you change the pressure. So there are two factors in the lungs that impact compliance. One is the stretchability of the tissues, and so that shouldn't vary too much unless some sort of disease is impacting the lungs. And that's possible, and we'll talk about some of those problems. But the main one, and the one that we want to talk about now that is the biggest influence in healthy lungs, is surface tension. Surface tension is, of course, present as a result of the fact that each alveolus is a very small structure, a microscopic structure, and the inside of that alveolus is lined with water. And so those water molecules form hydrogen bonds with one another, and those hydrogen bonds attract the water molecules together. And so that's, of course, what creates surface tension in any scenario, and why surface tension exists in the lungs, because you have 300 million little alveoli, each one exerting surface tension, and so that surface tension is significant when you look at the sheer volume of surface area that you're dealing with. Now, surfactant plays a huge role in reducing surface tension within the lungs. As you recall, surfactant is released by type 2 alveolar cells. Surfactant is a mixture of lipids and proteins, but the major component is a phospholipid that has a hydrophilic end that inserts itself between the water molecules and disrupts those hydrogen bonds. And so surfactant then it's actually absolutely necessary for life to occur, because it would be so difficult, the lung compliance would be so low without surfactant that it would be very hard to even take a single breath, and eventually you would become exhausted and it would be impossible to breathe without the presence of surfactant. So as we leave the slide, we want to glance briefly at this graph, which shows us the significance of compliance in lung function. So on the y-axis, we have lung volume. On the x-axis, we have the transpulmonary pressure, which we remind ourselves is the difference in pressure in the between the intrapleural space and the alveolus. And what we notice is that under normal circumstances, shown in green here, that as we increase the transpulmonary pressure, we have this increase in lung volume. But if we increase the compliance, that means we make the lungs more stretchable. And so we apply just a little bit of pressure, and we get a larger increase in lung volume as a result of that. And there are instances in which we'll increase the compliance, as we'll see shortly. But then another possibility is we decrease the compliance. And so, for instance, insufficient surfactant would decrease the compliance of the lungs. And in this case, we see that we increase the transpulmonary pressure, but we get less of an increase in lung volume as a result of that increase in pressure. Surfactant plays a huge role in normal lung function. The law of Laplace helps us understand the role that surfactant plays. And so if we look at that law, we see that pressure, according to the law, pressure equals 2 times the surface tension divided by the radius of the area. And so this means that as radius decreases, the pressure increases, or conversely, as it states on the slide, as the radius increases, the pressure decreases. And that's important in the lungs for this particular reason. And so let's say that we have an alveolus here and an alveolus here. B has a much smaller radius than does A. And so according to the law of Laplace, then what we see is that A is, the tension in A would be the same as tension in B in the absence of surfactant. This is if no surfactant is present. Then this means that the pressure will be greater in B than in A, so the air that's in B would flow over to A and B would collapse. Now, surfactant saves us from that, and so if that happened, then we would have half the, in this little subcompartment of the lung, we would have half the overall oxygen absorption capacity, as opposed to having 2 alveoli in order to use for oxygen extraction. If we look over at the right-hand side of our diagram, then we have surfactant present, as is the case in vivo, in the real world, in organisms. And interestingly, the important thing to understand is this, that as the surface area decreases, in other words, as the radius decreases, then the effect of surfactant becomes more and more pronounced. You could imagine those surfactant molecules becoming packed more and more closely together as the water molecules and the surfactant molecules that are on the surface of the alveolus became simply bunched up more tightly as the overall size of the alveolus decreased. And so you could imagine if that occurred, that those surfactant molecules would have a greater role in decreasing the hydrogen bonds that are found between the water molecules. And that's exactly what surfactant does. So in other words, if the size of an alveolus decreases, the influence of the surfactant increases, and so this balances out the law of Laplace, which says that as the size of the alveolus decreases, the pressure increases. That would eventually lead to collapse, but because of the opposing force of surfactant, this prevents collapse and allows the majority of our alveoli to remain open and therefore available for oxygen absorption. Moving on to a different but related topic, we see that the role that surfactant plays in lung function is well illustrated by, once again, a disturbing pathology. And so this particular disorder is referred to as respiratory distress syndrome, and it occurs typically in prematurely born babies who are not secreting sufficient surfactant. So these infants then have a very difficult time taking their first breath, and then as they exhale that first breath, their lungs collapse once again because of the lack of surfactant in the law of Laplace. And then they continue this process. And sadly, what we see is that 30 years ago, half of the infants born with this disorder did not survive despite our best efforts. It's disturbing to remember, but John F. Kennedy and his wife had an infant born with this prematurely and had this disorder that did not survive. And so that's an illustration of where we were in medicine at that particular time. That infant certainly got the best treatment that was available, but we were not sophisticated enough at the time to save these infants. Today, most of them do survive as a result of the treatment with synthetic surfactants and the use of a respirator. We talked briefly at this particular point in our chapter about some ventilation disorders. And we begin with asthma. Asthma, of course, is characterized by these temporary episodes in which the smooth muscle found in the tubes leading down into the lungs that we have talked about over the first part of our chapter, the smooth muscle in those tubes contracts inappropriately, making breathing difficult. So this has many different causes, but some possibilities are allergies, viral infections, and sensitivity to environmental factors. And the bottom line is that as a result of this chronic inflammation that's brought about by one of these three factors, then the body responds in an inappropriate fashion to normal stimuli, which would cause ever so slight constriction of the smooth muscle that is located in the lungs. And so things like exposure to smoke or exposure to cold air cause this extreme vasoconstriction and therefore difficulty in breathing. The treatment for asthma involves first anti-inflammatory drugs, just glucocorticoids, to try to get rid of the inflammation. And then second, bronchodilators are used to try to enlarge the airways by relaxing the smooth muscle. And so, for instance, beta-2 adrenergic receptor agonists that mimic the impact of epinephrine are used to try to cause vasodilation. And muscarinic cholinergic receptor blockers are used to try to prevent the vasoconstriction that has been associated with those muscarinic receptors. Secondly, we talk about COPD, chronic obstructive pulmonary disease. And so COPD is typically emphysema, chronic bronchitis, or both. So chronic bronchitis is defined as an excessive production of mucus as a result of inflammation in the bronchi of the lungs. And so you eventually have these thickened airways and difficulty breathing because of these mucus plugs that form in these airways. This can be a long-term condition as a result of smoking or exposure to some sort of environmental pollutant, typically in a work situation, or it can be temporary as a result of a viral infection, in which case after a couple weeks, then it typically clears up. Now, emphysema is different. Emphysema is the result of exposure well, it varies, we should first say, but typically it's the result of exposure to some factor outside the body. The most common cause is smoking, but exposure to environmental pollution, again, typically in a work setting, is also another cause. And so in the case of emphysema, you have damage to the alveoli. The alveoli, in some cases, actually the walls are damaged, and so one alveoli collapses into another, and so overall you lose surface area in the lungs, and therefore you, of course, are losing capacity to extract oxygen from the air. And so emphysema and bronchitis together are causes of COPD. In fact, they're nearly always the causes of COPD. And COPD is one of the main causes in the United States of disability and even death. We close our chapter by taking a look at some of the volumes and capacities that we use to assess lung function. And so we'll describe most of these by looking at this figure from our text. It's found on the right-hand side of our screen. We begin with tidal volume. And so tidal volume is the normal volume of air that enters the lungs and then exits in a normal inspiration and expiration. 500 mils for an average sized person would be a typical tidal volume. And so we see the tidal volume here, up and down, up and down, up and down. and that's 500 mils. So after a normal inspiration, you can inspire additional air. And so what we see is that the inspiratory reserve volume, shown from here to here, is the maximum amount of air that you can inhale above the tidal volume. And so it's typically about 3,000 mils. And so here we see a picture of a person inhaling first the tidal volume, if you're following the cursor, and then the 3,000 mils that comprises the inspiratory reserve volume. The functional residual capacity is shown here. And so we see that the functional residual capacity is the total volume of air that remains in the lungs after a normal expiration. And so in a typical person, it's 2,400 mils. It goes from right here all the way down to 0. Now, it is possible to exhale additional air after a normal non-forced expiration. And so that volume is referred to as the expiratory reserve volume. And so that's shown from right here to right there. That's typically 1,200 mils in an average person. And this means that about 1,200 mils remains in the lungs. And so this is called the residual volume, and this is a volume of air that cannot be exhaled. What we see is that there are a couple different tests that can be done to use these volumes to test lung function. The vital capacity is the maximum volume of an air a person can expire. And so this means that they're taking a breath as deeply as they possibly can, inhaling first the tidal volume and then the inspiratory reserve volume. And then they're exhaling the inspiratory reserve volume, the tidal volume, and then the expiratory reserve volume. And so this is a good measure of the flexibility of the lungs. You would expect this, if we go down to the second bullet point here, you would expect this to be reduced if there's some sort of restrictive lung disease like pulmonary fibrosis, in which the elastic tissue of the lungs has been replaced with fibrous tissue that's not elastic. A different test is the forced expiratory volume in 1 second, known as an FEV1. And in this particular case, what we see is that a healthy person can exhale about 80% of their vital capacity in 1 second. And so what we're interested in is the ratio between the FEV1 and the vital capacity. In obstructive lung diseases, in which the airways of the lungs are obstructed, such as in asthma, then people typically have a reduced FEV1. It's somewhat below 80%. Lastly, we look at some aspects of ventilation related to the number of breaths that are taken per minute. And so we use the term minute ventilation to describe the total amount of air that makes its way into and out of the lungs per minute. And so typically it is equal to the tidal volume times the ventilation rate. What we also notice is this, that there's an anatomical dead space that's depicted in the diagram at the upper right-hand side of our slide. And so what we see is that this anatomical dead space is made up of the trachea and some of the larger bronchi, and the air that's found in the pharynx. And so it's equal to about 150 mils in an average person. And there's just no way to get rid of this air. In other words, when you exhale, then at the end of exhalation, there's this air that has already had oxygen removed from it, or at least the majority of the oxygen moved from it, that rest in those airways. And so that's 150 mils. This means that when you take your next breath, what we see is that this 150 mils, if we follow this diagram to the right, gets pushed down into the lungs. And if you're taking an average size breaths, you're inhaling with your tidal volume 500 mils. So you have another 150 mils of air that ends up in this anatomical dead space. And there's only 350 mils of fresh air that makes its way down into the lungs, because the 150 mils that was in this dead space has now been pushed down into the lungs. So the important thing in this diagram is that although you inhaled 500 mils of air, you're only receiving 350 mils of oxygenated air. And so this means that the alveolar ventilation, in other words, the volume of fresh air, oxygenated air that's exposed to the alveoli, is different than your minute ventilation. For instance, we calculate, as we see here, the alveolar ventilation as the minute ventilation, or as the tidal volume, minus the anatomical dead space, which is 350 mils, and then we multiply that times the breaths per minute. And so this, of course, is what's important in determining gas exchange. The deoxygenated air that was resting in that anatomical dead space is of no use as far as the provision of oxygen for oxygen exchange. This means that the frequency and the volume of breaths that are taken have a huge impact on the alveolar ventilation rate. So we see some interesting calculations from your text here. We see that, let's do this one first, B. And so if you're taking average size breaths, your tidal volume is 500 mils, for instance, and 12 per minute, then your minute ventilation is 6,000 mils. And what we need to do then is look at the anatomical dead space that's making its way into the lungs in that particular time as well. In other words, the volume of air that was in the anatomical dead space that makes its way down into the lungs. And so that, of course, is 150, because as we saw up here, with each breath, there's 150 mils of deoxygenated air that's pushed down into the lungs, as we know. So 150 times 12 is 1,800. 6,000 minus 1,800 is 4,200 mils of oxygenated air that makes its way down into the lungs. And so that's fine. We just want to realize that that's less than the minute ventilation of 6,000. Now, on the other hand, we could go this way. Let's say that we take very shallow breaths. And so our tidal volumes in this case are only 150, but we take a lot of them. We take 40 per minute, and so 150 times 40 is 6,000. So that's equivalent to the minute ventilation that we had in our last example. But in this case, the anatomical dead space, of course, it doesn't change, but we have more breaths per minute. So we have a total of 6,000 mils of deoxygenated air that makes it down its way down into the lungs. And so if we subtract the minute ventilation from the anatomical dead space, we have 0. In other words, we have no oxygenated air that's making its way down into the lungs, and breathing in this manner eventually will result in loss of consciousness. Conversely, we could take a smaller number of breaths, but a greater tidal volume. So if we double our tidal volume, we can inhale much more than this, as we saw on the previous slides. But if we just double our tidal volume and take just 6 breaths per minute, then that, of course, gives us the minute ventilation of 6,000 mils per minute. But in this case, the anatomical dead space ventilation has been decreased. So it's 150 times 6, which is 900. 6,000 minus 900 is 5,100. So we're actually better off taking deeper breaths, half as many deeper breaths, as we can see, versus the example that we started with there. So what's the take-home message of all this? The take-home message is that when we consider gas exchange, which is represented by the alveolar ventilation, we have to consider this anatomical dead space that is, we defined as the deoxygenated air that ends up in these airways. So we just can't push that out. But when we inhale our next breath, that deoxygenated air gets pushed back down into the lungs where it just came from. And so this means that taking fewer, deeper breaths is more effective because it increases the alveolar ventilation versus taking a large number of very shallow breaths.